Welcome. We're focusing today on acute respiratory distress syndrome. It has, frankly, devastating mortality rates and demands immediate, precise action from clinicians. Let's start right at the beginning then. What is the core fundamental definition of acute respiratory distress syndrome?
Okay, simply put, it's a life-threatening type of acute respiratory failure, and it's driven by severe diffuse inflammation across the lungs.
Okay, life-threatening failure.
And critically, the failure itself is hypoxemic, meaning low oxygen levels, and it's explicitly not caused by cardiogenic reasons. You have to rule out heart failure or simple fluid overload as the primary driver.
That non-cardiogenic distinction is key, isn't it? So how does this inflammation actually damage the lung structures? What's the mechanism?
Well, it's really a cascade. You get this dysregulated systemic inflammation that targets and damages two crucial barriers in the lung.
Which are?
The alveolar epithelium, that's the lining of the air sacs, and the pulmonary endothelium, which lines the tiny blood vessels right next to them. This damage makes both layers much more permeable, leaky, basically.
Okay, so the barriers break down, they start leaking. What does that look like physically inside the lungs?
You get fluid flooding into the air spaces. That's the non-cardiogenic pulmonary edema. You also see the formation of these hyaline membranes lining the alveoli.
Right.
And you get widespread collapse of small lung units, atelectasis. The overall result, the lungs become incredibly stiff, compliance drops drastically, and gas exchange is severely impaired.
Which leads us straight into how we diagnose it. The 2012 Berlin definition is our guide here. Can you walk us through the four mandatory components, what absolutely has to be there?
Yes, the Berlin criteria are quite strict. Four things. First, timing. The onset has to be acute within 1 week of a known clinical insult, something like pneumonia, sepsis, trauma.
Okay, within a week, what second?
Second, imaging. You need to see bilateral opacities on the chest X-ray or CT scan. Think white areas in both lungs. And importantly, these can't be fully explained by effusions, lung collapse, or nodules.
Got it. Bilateral opacities.
Third, origin of the edema. As we said, the respiratory failure can't be fully explained by cardiac failure or fluid overload. Practically, this often means you need an echocardiogram to rule out a primary cardiac cause, especially in complex cases.
Makes sense. And the fourth component?
Fourth, oxygenation. This is really the numerical cornerstone. It's measured by the ratio of arterial oxygen, partial pressure to the fraction of inspired oxygen.
And there's a specific requirement for measuring that ratio, isn't there? About PEEP.
Exactly. You must be applying at least 5 centimeters of water of positive end expiratory pressure, or PEEP or CPAP, for non-intubated patients to even calculate this ratio for the definition.
Why is that minimum PEEP level so important for standardization?
Good question. It ensures we're comparing apples to apples. Without that minimum PEEP, you might just be measuring hypoxemia because of easily reversible atelectasis collapsed lung tissue that a bit of pressure could open up.
I see.
Requiring that minimum 5 centimeters of H₂O reflects the true severity of the lung injury itself, not just suboptimal ventilator settings initially.
Okay, so that ratio becomes our tool for stratifying severity. Let's break down those levels. What are the 3 tiers? And crucially, what's the associated mortality risk for each?
Right, clinicians really need to know these numbers. Mild ARDS is defined by a ratio between 200 and 300 millimeters of mercury. The associated mortality here is roughly 27%.
Still high, but that's the baseline.
Yes. Then we have moderate ARDS. That's a ratio between 100 and 200 millimeters of mercury.
Yep.
And the mortality risk jumps up noticeably to approximately 32%.
Okay, a significant increase. And for the most critically ill, the severe category.
Severe ARDS is defined by a ratio of less than 100 millimeters of mercury. These patients are the toughest to manage, and unfortunately, their associated mortality climbs steeply to about 45%.
Wow, nearly half. That really underscores the need for rapid, appropriate escalation of care.
It absolutely does.
Given that risk, identifying the trigger is paramount. What are the common clinical insults that lead patients down this path?
We usually group them into direct lung injuries, pulmonary causes, and indirect insults, extrapulmonary causes.
Okay, let's start with the direct ones.
The most common direct cause by far is pneumonia. Bacterial, viral, fungal severe pneumonia is a major trigger. Others include aspiration of gastric contents and pulmonary contusion, like from significant chest trauma.
And the indirect triggers, the ones starting elsewhere but causing that systemic inflammation.
Sepsis is the big one here. Uncontrolled infection leading to a systemic inflammatory response is a major indirect driver. Others include severe trauma, even without direct chest injury, massive blood transfusions, and acute pancreatitis. They all generate that widespread inflammation that damages the lung barriers.
So for the clinician seeing these patients arrive, often in the ED or maybe the OR, what are the immediate essential steps? Swift action seems mandatory.
It absolutely is.
Yeah.
You need to stabilize the patient while simultaneously starting to address the underlying cause. First, secure the airway if needed, and start oxygen therapy immediately to correct the hypoxemia.
Airway, oxygen, what's next?
Identify and aggressively treat the underlying trigger. If you suspect sepsis, get cultures and start broad-spectrum antibiotics right away. If there's a source of infection, it needs to be controlled.
And fluid management. That seems like a real balancing act early on.
It is. It's critical. You have to avoid fluid overload because that will absolutely worsen the pulmonary edema. But you still need to ensure the patient has adequate systemic perfusion, especially if they're in shock.
So resuscitate, but then be cautious.
Exactly. Resuscitate from shock, then transition quickly to a conservative fluid strategy, aiming for neutral or even slightly negative balance once they're stable. And importantly, initiate lung protective ventilation early, often right from the time of intubation. Don't wait.
Let's talk about that cornerstone, lung protective ventilation. The evidence is clear, it reduces mortality. What are the specific settings, the non-negotiables every provider needs to implement?
The core principle is simple: gentle ventilation. Smaller breaths, lower pressures. So first, tidal volume must be low. We target 4 to 8 milliliters per kilogram of predicted body weight.
Predicted body weight, that's crucial, right? Not actual weight.
Absolutely critical. Using actual weight, especially in obese patients, can lead to dangerously large breaths for their lung size. You calculate predicted weight based on height and sex.
Okay, low tidal volume based on predicted weight. What about pressure limits?
We need to limit the pressure applied to the lungs during inspiration. The plateau pressure, measured during a brief pause at the end of inspiration, must be kept at or below 30 centimeters of water, rigorously.
Below 30 centimeters H₂O, why that number?
Exceeding that significantly increases the risk of barotrauma, physical lung injury, from excessive pressure.
There's also been a lot more focus recently on driving pressure. What is that and what's the target?
Right, driving pressure has emerged as a really important predictor of outcome. It's simply the difference between the plateau pressure and the PEEP level. Plateau pressure, PEEP. It represents the stretch the lung sees with each breath.
And the target?
We aim for a driving pressure of less than 15 centimeters of water. There's strong evidence linking lower driving pressure, ideally below 15, to improve survival. Some would even argue it's more important than the absolute plateau pressure, though both matter.
So if you're struggling, prioritize keeping that driving pressure low.
That's often the thinking, yes.
Yeah.
Minimize that cyclic stretch.
And where does PEEP fit into this lung protective strategy? What's its main role?
PEEP is used to keep the alveoli open at the end of exhalation. We use moderate to high levels, often titrated based on oxygenation and compliance using established tables or methods. The goal is to recruit collapsed lung units and prevent them from collapsing again with each breath, which is also injurious atellect trauma.
Okay, so that's the ventilator foundation. For patients with moderate to severe ARDS, what other therapies, adjunctive therapies, should we be using?
For moderate to severe cases, prone positioning is now considered essential, not optional. If the PaO₂ ratio is low, typically below 150, you need to prone the patient.
Turn them onto their stomach. How does that help?
It improves ventilation perfusion matching. It helps recruit collapsed lung areas in the back, dorsal regions, and shifts blood flow. The data shows a clear mortality benefit. It should be done early and typically for extended periods, like 12 to 16 hours per day.
12 to 16 hours daily. What about medications, neuromuscular blockers?
Neuromuscular blocking agents like citracurium can be very useful, particularly in the early phase, maybe the first 48 hours, of severe ARDS.
Why use paralysis?
Their main benefit is to prevent ventilator dysynchrony. If the patient is agitated or fighting the ventilator, their own respiratory efforts can generate harmful pressures and volumes. Paralysis allows the ventilator to deliver that lung protective strategy perfectly without interference.
Makes sense for short-term use in severe cases. We touched on fluids earlier. What's the approach once the initial resuscitation phase is over?
Once the patient is hemodynamically stable, the goal shifts definitively to a conservative fluid strategy. Aim for a net neutral or even slightly negative fluid balance each day.
Why the emphasis on keeping them dry?
Less fluid accumulation means less pulmonary edema, which can help shorten the time on the ventilator and potentially improve overall lung function as long as you maintain adequate organ perfusion.
And what about corticosteroids? There's always debate there.
Yeah, the steroid question is nuanced. Low-dose corticosteroids, like methylprednisolone, can be considered, But the key is timing.
Timing.
They should generally be started within 14 days of ARDS onset, if used. There's some evidence they might reduce inflammation and improve outcomes when started early. However, starting them late after 14 days seems to be associated with worse outcomes, potentially increased risk of infection or muscle weakness, so it's generally avoided then.
Okay, early use, potentially beneficial, late use, potentially harmful. What happens when even all these measures, lung protection, proning, maybe neuromuscular blockers aren't enough? When do we consider ECMO?
ECMO, specifically veno-venous ECMO or VV ECMO, is really a salvage therapy. It's reserved for patients with severe ARDS who remain refractory, meaning unresponsive to all the optimal conventional therapies we've just discussed.
So they have to have failed optimized ventilation, proning, perhaps paralysis.
Exactly. They need to have had a good trial of maximal medical therapy. The typical indications involve persistent severe hypoxemia.
Is there a specific number for that?
Yes, usually a ratio persistently less than 80 millimeters of mercury despite everything, or sometimes less than 50 for a few hours. Another indication can be uncompensated hypercapnia, high CO2 levels, causing severe acidosis, like a pH less than 7.20, that can't be managed with a ventilator due to the lung protection constraints.
And this requires specialized centers, correct?
Absolutely. ECMO is complex and requires a highly specialized team and infrastructure. Patients meeting criteria are typically transferred to designated ECMO centers.
Even with these advanced therapies, overall mortality remains high, somewhere between 30 and 50%, as you mentioned. For those who do survive, what's the long-term picture? What challenges do they face?
Survival is just the first hurdle. The long-term impact, what we sometimes call post-intensive care syndrome or PICS, can be profound and multifaceted. Survivors often have significantly reduced lung function that can persist for months or even years.
Beyond the lungs.
Oh yes, profound muscle weakness, often called intensive care unit acquired weakness, is very common due to prolonged immobility and inflammation. Cognitive impairment, issues with memory, attention, processing speed is also frequent. And the mental health burden is huge.
What kind of mental health issues are common?
High rates of post-traumatic stress disorder, PTSD, depression, and anxiety are unfortunately very common among ARDS survivors. Think about it. They've endured a life-threatening illness, often prolonged mechanical ventilation, sedation, sometimes paralysis, delirium. It's incredibly traumatic.
It sounds like recovery is a very long road.
It really is. It requires comprehensive, long-term support, pulmonary rehabilitation, physical therapy, occupational therapy, psychological counseling, and ongoing medical care, often extending long after they leave the hospital.
So synthesizing all this, it really comes down to hitting specific, strict numeric targets in diagnosis and management, doesn't it?
Absolutely. The entire framework is built on these numbers, the Berlin criteria for diagnosis, and especially the ventilator targets. The 4 to 8 milliliters per kilogram predicted body weight for tidal volume, keeping plateau pressure below 30 centimeters of water, aiming for driving pressure below 15. These aren't just guidelines. They are standards of care proven to save lives by minimizing further lung injury.